the talk. These are two patients that I saw in clinic. The case number one is a 57-year-old Hispanic female. She was diagnosed with AIDS with a CD4 count of 5 and a viral load of 1 million in October 2009. When she presented with pneumococcal pneumonia, she was started on Truvada and boosted Persista. She had a history of hypertension, alcohol abuse, and tobacco abuse. In March of 2010, she was treated for culture-negative TB. Then in August of 2010, her CD4 count had gone up from 5 to 132, and her viral load was undetectable then. A couple of months later, she started noticing memory loss that was interfering with her activities of daily living. Her neurological exam was normal. So at that time, I did an MRI, and you can clearly see here that she has bilateral white matter lesions on her brain. So I suspected that she was having HIV-associated neurocognitive disorders. We did a lumbar puncture to rule out everything else. There's white cells was 1, glucose and protein were negative. There was no syphilis. JC virus was negative. Her cryptococcal antigen was negative. So I presumed this was HIV. We changed her regimen to a more CNS active regimen. She was on Truvada, so we switched to Combivir and then to Epsicon with boosted Persista. We gave her a month of prednisone, and her memory improved significantly. This improvement, though, was only temporary. 3 years or so, then she started noticing a decline in her memory as well. Case number 2, 37-year-old African-American female. She was again diagnosed with AIDS in 1996 when she came in with cryptococcal meningitis. Her HIV was treated with Truvada and Lexiva since 2004 and had good immunological response. In February 2008, she became pregnant, so she was switched to Truvada and Reatas. In June of 2008, her CD4 count was 416. Her viral load was really low level at that time. A couple months later, she started developing diplopia, unsteady gait, multiple falls, dizziness. Her neurological exam is significant for left lateral nystagmus, right ptosis, horizontal diplopia, and she's unable to do tandem gait. Her MRI again shows bilateral white matter lesions. We do a spinal tap, and she does have a pleocytosis, 54 white cells. Her glucose is normal, protein is very high. So we looked at everything. We sent everything we can send to rule out an infectious etiology. All the workup came back negative. So we got a brain biopsy that showed pale white matter with a lot of infiltrations, particularly by CD8 T cells. So the final brain biopsy result was basically consistent with AIDS encephalopathy. There's no evidence for PML, CJD, acid-fast, fungi, or bacteria seen in all stains. We did neurocognitive testing on her, and she had marked impairment in 3 domains: construction, language, and attention. Her ataxia worsened. She was falling. She was being admitted to the hospital for frequent falls. She was having headaches, weakness, diplopia, slurred speech. She could not take care of her kids. She had a 2-year-old daughter she couldn't take care of. So at that time, we switched her regimen from Truvada, Reatas, and Norvir to Epsicon Calitra, and again we gave steroids for a month, and she improved dramatically with the steroids and the change of the heart regimen. Within 2 weeks, the only thing she had mild ataxic gait, but all the other symptoms disappeared. So at that time, 2008, 2009, we looked at the definition of CNS iris. It was defined as worsening neurological status after initiation of heart, deterioration or new radiological findings, suggestive inflammation, a decrease in the viral load, and then excluding everything else, basically, and histopathology demonstrating T cell infiltration. So this patient definitely had CNS HIV iris. A couple years later, the French published a study in CID where they named it CD8 encephalitis. So this is a review of 14 patients from France. Very similar story to case number 2. In case number 1, memory impairment, ataxia, seizures, a lot of them being treated with steroids to decrease inflammation, and a lot of change into CNS active regimens, and documented decrease in the viral loads. Scott Latendre, who's a main investigator in HIV neurocognitive disorders from San Diego, had the editorial in CID, And basically, he thought that the CD8 encephalitis is the tip of the iceberg. We're seeing those severe cases being reported, but there's a lot of other patients that are not being diagnosed or even treated. It was good that in this report, 9 out of the 14 patients survived. And again, he comments that it's basically because of the use of steroids that has decreased the inflammation, possibly improved the survival of those patients. In the French study, they did flow cytometry, and all the patients had a CSF CD8 T cell percent greater than 65. So in the editorial, he comments that brain biopsies are not very easy to get. If you have a flow cytometry and you see that CD8 T cells are more than 65, you can make a presumed diagnosis of CD8 encephalitis. Also, in this study, they looked at CD38. There were 3 cases that were CD38 positive. So what's the CD38? Well, it's a glycoprotein that is expressed on immature B cells and T cells, and basically it's a marker of T cell activation, suggesting there's some persistent low-level viral replication causing this T cell activation, and hence the CD8 infiltration in the brain biopsy. So we submitted the CSF and the brain tissue to Avi Nath. He's the director of the NIH in the NeuroAIDS division there, and he looked for TAT antigen, and he found it in the CSF and in the brain in our patient. So there was evidence for replicate antigens, HIV antigens in the brain, even though the patient at the time of the brain biopsy had a viral load in the serum that was completely suppressed. So what's the difference between HIV encephalitis and CD8 encephalitis? So HIV is basically the patients come in, they're not on heart, they're newly diagnosed, biopsy shows multinucleated giant cells, there's very little infiltration of lymphocytes, and you see a lot of HIV antigens. In CD8 encephalitis, typically are the patients that we're seeing now are on heart with virological response. There's no multinucleated giant cells. There's a lot of CD8 infiltrations, and there's scant presence of HIV antigen. So it's very important to make the distinction between those two syndromes because they can behave similarly. This is a study, again from CID, looking at the discordance between the CSF and the serum genotypes in patients that had viral loads less than 50. So there's a phenomenon called viral escape. Patients can have a suppressed viral load in the serum, but detectable CSF viral load in the CSF. And in those patients, they were able to see discordant genotypes because low level, and you're selecting out resistant viruses in the CSF that you're not even aware in the serum. So that is another problem as well that has to be tackled. So what is the criteria for neurocognitive disorders? You can have a neuropsychological deficit if it's only an abnormality in one cognitive ability. If you have 2 or more cognitive abilities, and there's, you call it ANI, asymptomatic neuropsychological impairment. If that is associated with functional impairment, then it's called mild neurocognitive disorder. And then if it's marked deficits with marked functional impairment, it's called HIV-associated dementia. So the definition for ANI is basically you need to have at least 1 standard deviation below the norms on 2 different domains. The functional impairment has to be seen for at least a month, so it's not a transient thing. You rule out delirium or dementia, and there's no other things that is explaining the comorbidities of the neuropsychological deficits. Again, MND if you have interference with active daily living, and HIV when it's marked. So in this study, patients that had viral loads less than 50, they're all suppressed, 200 patients. If they had cognitive complaints, 80% of them had some sort of hand. If they had no complaints, 60% of them had some degree of hand. Obviously, in the patients with no complaints, the majority were asymptomatic versus those that were having cognitive complaints. But overall, in this 200 patients, you see the high rate of neurocognitive impairment, very similar to what we see in our clinic, as we'll discuss later. So there's a review article, again, by Avi Nath, where he clearly explains the risk factors for HIV-associated neurocognitive disorders. You have HIV disease risk factors, so low CD4 count nadir, basically what the CD4 count was at baseline, like our two patients, they were both patients with AIDS. Older age at seroconversion, the studies have shown at age greater than 50, one of our patients was 57. Duration of HIV infection, one was diagnosed in 1996, so the longer you're affected with HIV. Presence of AIDS-defining diagnosis, like our patient with cryptococcal meningitis, some particular HIV variants, viral load in the CSF that's detectable, so a detectable CSF viral load would be a factor. Then comorbidities, again, older than 50, anemia, vascular disorders, co-infection with hepatitis C, that's something that we see a lot in our clinics, around 15-20% have co-infections. And then host genetic factors like polymorphisms in apolipoprotein 4 and CCR4 and MCP1. HIV has a lot of gene products that can give you neurotoxicity. So in the envelope gene, you have GP120 and GP41. This can block glutamate uptake, can release cytokine, and induces INOS. TAT is the transactivator of transcription, can also give you cytokines and directly excite the neurons. REV disrupts cell membranes. VPR or viral protein R can insert in cell membranes and create ion channels. And NEF can also inhibit channels and behaves like the scorpion's neurotoxin. So a lot of neurotoxic effect from the gene products on HIV. And you have the non-inflammatory pathway and the inflammatory pathway. So the non-inflammatory pathway, basically you're interrupting the trophic factors required for growth and health. So you're blocking glutamate. In the inflammatory is basically all the cytokines, TNF alpha, interleukin 1 beta, interleukin 6, MCP1, nitric oxide. So it's a hit and run hypothesis. So there's a lot of biomarkers that have been studied looking at association with hand, some due to astrocyte activation, some macrophage activation biomarkers, some neurotoxins, and some markers of neuronal injury like neurofilament light. There's a bigger list. This is just a partial list. There's a lot of other ones. So again, like I pointed out before, I think it's very important for the CNS penetration of antiretrovirals in this syndrome because we're seeing a lot of patients. Scott Latendre, again, did a CNS penetration score. He initially did it in 2008, and then he updated in 2010. To my knowledge, there's no updated one yet. But basically, it classifies the CNS activity of the different antiretrovirals by group. And tenofovir, as you probably know, is the backbone of our treatments. If you look at the guidelines, they recommend tenofovir. And Truvada is everywhere. So we use a lot of Truvada that has a category 1 here. That's why I usually switch my patients from a Truvada-based regimen to an abacavir-based regimen because of this increase in CNS penetration. Obviously, when I do that, I need to check an HLA-B5701 to try to prevent the allergic reaction. But you see, all of them, you just sum it up, and you can come up with your own score. So in general, the studies have shown that the lower, if it's less than 8 or 7 or below, that's associated with worse neurocognitive disorders, and a CPA greater than 8. So when you look at our clinic, the majority of patients are taking Truvada-boosted Reatas. Case 2 was taking Truvada-boosted Reatas, or Truvada-boosted Persista. That was case 1. A tripla. A lot of patients are taking a tripla on our clinics. Truvada, raltegravir. All those are the 4 preferred regimens in the DHS guidelines. So now, if you look at Combivir, we're not using Combivir that often because it has ACT, and ACT gives you anemia and can also give you other problems, nausea and vomiting. So we've shied away of using Combivir. Epsicon, that has abacavir, has higher CNS penetration, but you have to do the HLA-B5701. Obviously, this differentiation is not in the guidelines yet. They're not recommended to test for neurocognitive disorders and to pick your regimens based on that. But once you have a patient that is actively having problems, I think it's wise to switch them. Again, this is the first study looking at viral escape. 69 patients on heart with viral less than 50. 10% had detectable viral loads in that study. There's a lot of clinical trials that have been looked at, but none of them have been effective. So there's really nothing, to my knowledge, in the horizon to how to treat hand in the post-heart era. So how do we screen for hand? This is a brief neurocognitive screen. You can do the trail making A and B. We basically time the amount of time that the patient takes to go to 1, to 2, to 3, to 4, to 5, 6. And then you can also do the ways, digit symbol task, where basically you gotta look at this and then just put here, well, 2, I'll draw this, 1, I'll draw a line, and the time it takes you to do that. So this is in the literature. It's not very sensitive. The ROC curves, you can see them around the 60%. So you want a highly sensitive test if you're going to use it in a big population of patients. So what we did, we looked at the MoCA. The MoCA is the Montreal Cognitive Assessment Tool. It's free, it's online, it's in 30 languages, and there's instructions to do it, and it takes you 10 minutes to do. And you score all this out of 30. If it's less than 26, the patient has neurocognitive impairment. So we screened 100 patients, and in our clinic, 75% of the patients coming in for the first visit had cognitive impairment. So just before heart, we're coming in with a population where 75% are already having memory problems. The MoCA, less than 26, was present in 64 out of the 75 patients with cognitive impairment, as documented by a full battery of tests. And here, 15 were less than 26 out of 25 with no cognitive impairment. So the sensitivity was around 80-something%, but it's better than 60%, and it's widely available. Okay, and we just did a follow-up study on this study just now, looking at retention in care. That's going to be published this month in AIDS. And basically what it shows is that neurocognitive impairment is associated with lack of retention in care, especially in patients with the age of 50 and above. So it's also important for retention in care. Okay. Any questions?